Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this video, I will be explaining you glycogen storage diseases. Now let's get into individual glycogen storage disorders. Now the glycogen storage diseases, these are genetic diseases because of a defect in an enzyme that is involved in either glycogen synthesis or glycogen degradation. Now here in these disorders, there can be an accumulation of excess glycogen which has got an abnormal structure, or it can be an accumulation of a glycogen which has got a normal structure but in excess quantities. So glycogen storage diseases may affect a single tissue like a specific tissue like liver, or it can affect a specific tissue like muscle, or it can be more generalized disorder. And the severity of glycogen storage diseases, it can go from mild to a fatal condition. So these are some of the general features here for glycogen storage disorders. Now let's get into the specific glycogen storage diseases. Now the table here is giving you all the glycogen storage diseases names here as one space, where you can see enzyme deficiencies that are directly or indirectly involved in glycogen metabolism. So we have glycogen synthase enzyme. Deficiency of that can lead to hypoglycemia, hyperketonemia, early death. And then we have endoplasmic reticulum located glucose 6-phosphatase transporter, that is glycogen storage disease 1B, which we are going to see, where patient will have neutropenia and impairment in neutrophil function leading to recurrent infection. And glycogen storage disease 1A is a von Gierke disease. That's because of glucose 6-phosphatase enzyme deficiency. You know, glucose 6-phosphatase is the final enzyme in the conversion of glucose coming from glycogen degradation or gluconeogenesis. We are going to go into details of this enzyme. Then we have glycogen storage disease type 2. Type 2 glycogen storage disease is Pompe disease, and the Pompe disease is because of lysosomal alpha-1,4 and alpha-1,6 glucosidase enzyme deficiency. Together it is called as acid maltase enzyme deficiency. And this is a fatal condition because it occurs in early infancy and it may lead to death because of cardiac failure by the age of 2 years. Now glycogen storage disease type 3 is called as Cori's disease, and the Cori's disease can be further divided into type 3A and type 3B based on where exactly is the debranching enzyme that is deficient. If the debranching enzyme is deficient both in the liver and muscle, it is type 3A. If it is present, if the deficiency is seen only in the liver, it is type 3B. And then we have type 4 glycogen storage disease, that is Andersen disease. And the Andersen disease is because of deficiency of branching enzyme. And then the type 5 glycogen storage disease is McArdle's disease, and that's because of muscle glycogen phosphorylase enzyme deficiency. Type 7 is Hers disease because of liver glycogen phosphorylase enzyme deficiency. Type 7 is Tarui's disease, and Tarui's disease is because of deficiency of muscle phosphofructokinase and erythrocyte phosphofructokinase. So muscle and erythrocyte phosphofructokinase enzyme deficiency. Then we have unnamed disorders like type 8, type 9 and type 10 here. Type 8 is liver glycogen phosphorylase kinase enzyme deficiency. Type 9 is liver and muscle phosphorylase kinase enzyme deficiency together. and the type 10 is cyclic AMP dependent protein kinase A enzyme deficiency. Overall, if you look at the enzyme deficiencies, list of all the enzymes that are mentioned here, all these enzymes directly or indirectly, they are all involved in metabolism of glycogen. So defect in any of these enzymes may lead to a specific disorders, and that is what is mentioned in the types in column number 1. So types can start from 0. Type 0, as you see here, type 0 is, or you say type O instead of 0 there. So it is a glycogen synthase enzyme deficiency. And then we start from type 1A, type 1B, that is type 1A is a 𝗠𝐴𝐷𝐸 disease, type 1B, although name is not given, but it is a variant of that 𝗠𝐴𝐷𝐸 disease because of deficiency of glucose 6-phosphatase transporter. And then type 2 is Pompe disease, type 3 is Cori's disease, and that is again divided into type 3A and B, depending on where exactly the enzyme that is deficiency is found. Type 4 is Andersen disease, type 5 is McArdle's disease, type 6 is Hers disease, type 7 is Tarui's disease. And after that we don't have other names like type 8, 9 and 10, they are because of liver glycogen phosphorylase enzyme deficiency. That's because of liver glycogen phosphorylase kinase enzyme deficiency. And then type 9 because of liver and muscle, both the tissue affected, glycogen phosphorylase kinase enzyme deficiency. And then type 10 is cyclic AMP dependent protein kinase A enzyme deficiency. Before we get into specific disorders, let's group them into based on their common occurrence related with the specific organs, and also their frequency of these disorders in terms of most common in childhood, most common in adults, something like that. So in that way, we can group glycogen storage diseases as like type 1, type 3, type 4 and type 6 specifically. And even we put type 7 also here. So type 1, 3, 4, 6 and 7, these glycogen storage disorders, they are classified predominantly as the hepatic form of glycogen storage disease because liver is the predominant organ that is affected. So hepatic form of glycogen storage disorders. And that is type 1 is 𝗠𝐴𝐷𝐸 disease, type 3 Cori's disease, type 4 Andersen disease, type 6 is Hers disease, and type 7 is Tarui's disease, although Tarui's disease is predominantly more of skeletal muscle and red blood cells are affected in that, right? So coming to type 5 and type 7, type 5 is McArdle's and type 7 is Tarui's. So where it is a predominantly myopathic form of glycogen storage disease with the muscle being predominantly affected. And coming to the incidence of these disorders with the age of onset and all that. So the most common childhood disorders are type 1, that is 𝗠𝐴𝐷𝐸, type 2 is Pompe disease, type 3 Cori's disease, and type 9 it is liver glycogen phosphorylase kinase enzyme deficiency. The most common adult disorder is type 5, that is McArdle's disease. So like this, we can broadly group glycogen storage disorders as hepatic form and myopathic form, and also we have seen which type of glycogen storage diseases are most common in childhood and which type of glycogen storage disease is most common in adulthood. And also out of all glycogen storage disorders, the most common glycogen storage disease, irrespective of tissue specificity or age of onset, it is the glycogen storage disease type 1, and that is specially type 1A, and that is 𝗠𝐴𝐷𝐸 disease. 𝗠𝐴𝐷𝐸 disease is the most common glycogen storage disorder. Now let's get into von-Gierke disease. Von-Gierke disease, as I said in my earlier slide, it is the most common of all glycogen storage diseases. And the type 1 glycogen storage disease is further classified into type 1A, type 1B, type 1C and type 1D. In order to understand these classes of glycogen storage disease type 1 into 1A, B, C and D, we need to have an understanding of how exactly the glucose 6-phosphate, that is, now to understand the subclassification of glycogen storage disease type 1 into 1A, B, C and D, we need to understand how exactly the glucose 6-phosphate that is there in the cytoplasm, especially during glycogen degradation and gluconeogenesis process. See, the final step in the conversion of glycogen, which is giving glucose 1-phosphate, glucose 6-phosphate and converted to glucose in the liver, and also gluconeogenesis process where it is bringing lactate and alanine all the way back to glucose. So the last step in the gluconeogenesis and glycogen degradation to make glucose in the liver is the conversion of glucose 6-phosphate into glucose, and that will be done by enzyme glucose 6-phosphatase enzyme. Now this glucose 6-phosphatase enzyme, it is located in the membrane of endoplasmic reticulum as it is shown here in the figure. Now this glucose 6-phosphatase enzyme, since it is located in the membrane of endoplasmic reticulum and especially towards the lumen of the endoplasmic reticulum, that means a glucose 6-phosphate from the cytoplasm, it has to be transported into the lumen of endoplasmic reticulum, and that will be done through a transporter present over the membrane of endoplasmic reticulum, and the name of the transporter is a T1 translocase, and that is what is written here, T1 translocase, and it is shown here, glucose 6-phosphate transporter mentioned as T1 translocase, also written it as glucose 6-phosphate transporter is T1. Now when glucose 6-phosphate enters into the lumen of endoplasmic reticulum, in the lumen of endoplasmic reticulum, with the help of glucose 6-phosphatase which is attached to the membrane of endoplasmic reticulum, where its catalytic subunit is towards the lumen of the endoplasmic reticulum, it is going to take that glucose 6-phosphate and it's going to break that into glucose and inorganic phosphate. It goes like this. So glucose is released and inorganic phosphate is released. So it gets into this glucose 6-phosphatase enzyme and it breaks into glucose and inorganic phosphate. Now glucose and inorganic phosphate which is released there, so it will be getting out of the lumen of endoplasmic reticulum into the cytoplasm by a transporter called as inorganic phosphate transporter called T2 transporter or T2 translocase, which is allowing inorganic phosphate to come out of the endoplasmic reticulum into the cytoplasm, and the glucose will come out of the endoplasmic reticulum into the cytoplasm by T3 translocase, which is also called as a glucose transporter, that is T3. Okay, so like this, a glucose 6-phosphate which has to be converted into glucose in the liver, it need to go into the lumen of endoplasmic reticulum. So there are transporters in the over the membrane of endoplasmic reticulum. Now all of these T1, T2, T3 transporters and the glucose 6-phosphatase enzyme, since they are all proteins, so they are all coded by a specific genes, and if there is a mutation in a gene coding for that, so that can lead to different types of glycogen storage disease type 1A, which is subclassified into 1A, 1B, type 1A, type 1B, type C, 1C and type 1D. Now type 1A, GSD type 1A is because of mutation in G6PC gene, which is coding for glucose 6-phosphatase. That is 1A, which we call it as 𝗠𝐼𝐻𝐾 disease specifically. And then 1B is because of defect or deficient activity of translocase, T1 translocase. That is 1B. 1C is T2 translocase, that is inorganic phosphate transporter. And 1D is because of T3 translocase, which is the glucose transporter in the membrane of endoplasmic reticulum. So now this is how glycogen storage disease type 1 is further classified into 1A, B, C and D. Now let's get into a clinical presentation of 𝗠𝐼𝐻𝐾 disease, and that is 1A, glycogen storage disease 1A. So we are looking at 1A here specifically. What are the clinical presentation? So the clinical presentation here is doll-like face with fatty cheeks because of abnormal accumulation of triglycerides in the subcutaneous tissue like adipose tissue. Thin extremities with short stature because of the developmental delay, and the protuberant abdomen is commonly seen, and the protuberant abdomen is hepatomegaly. Along with that there will be renomegaly. Hepatorenomegaly is seen in 𝗠𝐻𝐾 disease because glucose 6-phosphatase enzyme is predominantly seen in the liver, in the deficiency or defect in the glucose 6-phosphatase enzyme, where glucose 6-phosphate is not going into glucose formation sufficiently. So that will lead to metabolic changes leading to hepatomegaly. And also, since glucose 6-phosphatase is located in the kidney, so 𝗠𝐻𝐾 disease type 1A will lead to renomegaly. So hepatorenomegaly is one of the feature of 𝗠𝐻𝐾 disease, and that will lead to protuberant abdomen. Patients with 𝗠𝐻𝐾 disease will show hyperventilation and apparent respiratory distress because of the metabolic acidosis. Patient may go into hypoglycemia, hyperlipidemia, leading to presence of xanthomas. Especially these are the fatty material which is accumulated just beneath the skin. And also patient will show hyperuricemia, giving rise to signs of gouty arthritis. Now, why patients with 𝗠𝐻𝐾 disease will show all these changes? Why patients with 𝗠𝐻𝐾 disease will show hypoglycemia, hyperlipidemia, hyperuricemia, lactic acidosis, ketoacidosis? There are so many metabolic changes will be going on in the deficiency of glucose 6-phosphatase enzyme. In order to explain that to you, in order to make sure that you understand the laboratory changes that goes on in 𝗠𝐻𝐾 disease in an abnormal way, in the metabolic abnormalities that is going on here because of deficiency of glucose 6-phosphatase. So I need to explain you by writing down the pathway so that you exactly understand why the metabolic abnormalities are seen here. So let's start from glycogen itself, glycogen degradation or gluconeogenesis. So in the gluconeogenesis, where lactate is, I'll be very brief in showing this, lactate which is going into pyruvate formation. Pyruvate will go all the way to glucose 6-phosphate. That's where is the defect glucose 6-phosphatase enzyme. That's from the gluconeogenesis side. Gluconeogenesis, making glucose. On the other side, glycogen degradation, where glycogen is breaking down into glucose 6-phosphate. And this glucose 6-phosphate has to be converted into glucose, and this happens in the endoplasmic reticulum, and that's where enzyme comes. Our enzyme, glucose 6-phosphatase enzyme, which is located in the endoplasmic reticulum. So that enzyme is defective here. We are looking at type 1A, so we are looking at glucose 6-phosphatase enzyme deficiency. So what I am going to do now is, I am going to cross it out. So just to show that glucose 6-phosphatase enzyme is not working. So what happens? So because of this, first thing that happens is under fasting condition, glucose levels in the blood will decrease. Why? Because gluconeogenesis and glycogen degradation, these are the sources for glucose under fasting condition. These are the pathways that will make glucose under fasting condition, especially in the liver, to make sure our blood glucose level is maintained, right? So gluconeogenesis will decrease, glycogen degradation will decrease because glucose 6-phosphatase enzyme is not working properly, or it is deficient, or if it is defective. So overall glucose level decreases, and that leads to hypoglycemia. So let's write it down now. Hypoglycemia. So patient will have fasting hypoglycemia. So that is one of the signs we see in 𝗠𝐻𝐼𝐸 disease or any glycogen storage disease type 1, and which is further classified into 1A, 1B, 1C, 1D. All of them we see like fasting hypoglycemia there. Now, because glucose 6-phosphate is not converted into glucose, so what will happen? So glucose 6-phosphate simply builds up because it is not going towards glucose formation. So this glucose 6-phosphate which is building up in the cytoplasm, it can go into different metabolic pathway. One of the metabolic pathway that glucose 6-phosphate can go is this glucose 6-phosphate. It can run down into glycolysis in the liver. It can run down into glycolysis and make pyruvate. And pyruvate, it has two fate. It can go into acetyl-CoA, and or pyruvate can be converted into lactate, because there will be plenty of pyruvate coming from glucose 6-phosphate. So pyruvate on one side going into acetyl-CoA, and acetyl-CoA, it will be converted into citrate. Acetyl-CoA converted to citrate, and 𝐒𝐶 cycle going on. That's one thing. Citrate, which can move out of mitochondria into the cytoplasm, and citrate is diverted in the cytoplasm. Citrate can go into fatty acid synthesis. I'll write it as FA synthesis. FA means fatty acid synthesis, and that fatty acid can become triacylglycerol, and triacylglycerol is elevated in the blood. Basically, we'll see VLDL formation. VLDL levels will be elevated in the blood, and excess VLDL means excess triacylglycerol, and that is causing hypertriacylglycerolemia. Hypertriacylglycerolemia, one of the signs that you see in 𝗠𝐻𝐼𝐸 disease. Not only fatty acid synthesis going on here from citrate in the cytoplasm, even cholesterol synthesis will go on. Cholesterol formation. And this cholesterol, again, it will become part of VLDL. So there will be excess VLDL there, leading to excess cholesterol. So hypercholesterolemia. Hypercholesterolemia is another sign that you see in 𝗠𝐻𝐼𝐸 disease. So together it is hyperlipidemia. Excess cholesterol and triacylglycerol, it is hyperlipidemia. So that is because of diversion of acetyl-CoA into 𝐶 cycle, citrate moving out of mitochondria into the cytoplasm and diverted into fatty acid and cholesterol biosynthesis. Note that fatty acid synthesis is a reductive biosynthesis, cholesterol synthesis is a reductive biosynthesis process. So that needs NADPHH+. How NADPHH+ come from? Because there is so much fatty acid and cholesterol synthesis going on. So NADH has to come from somewhere. So for that, NADH is coming from same glucose 6-phosphate, which is diverted into pentose phosphate pathway. That is exose monophosphate shunt. PPP here is pentose phosphate pathway. So what is the product of pentose phosphate pathway? Product of pentose phosphate pathway is NADH plus H plus, and that NADH H plus which are increased here, and they are used for fatty acid synthesis and cholesterol biosynthesis. So I am going to put a dotted line here to show that they support fatty acid synthesis and cholesterol synthesis. Now the other product of pentose phosphate pathway is ribose 5-phosphate. Ribose 5-phosphate, and this ribose 5-phosphate will make PRPP. PRPP is phosphoribosyl pyrophosphate. You are going to see that in purine and pyrimidine metabolism. And this phosphoribosyl pyrophosphate, it is going to increase purine salvage pathway. So PRPP, it is diverted into a purine salvage pathway. And this purine salvage pathway will increase purines. There will be increase in purines, and these purines will be degraded because they will be synthesized in increased quantities. Purine degradation will give uric acid, and uric acid levels will be elevated. And elevation of uric acid levels in the blood is called as hyperuricemia. And hyperuricemia or increase in the uric acid is also because of elevated lactate. You know, lactate, there is excess lactate which is seen in the 𝗠𝐴𝐲𝐽 disease. It is because, let me explain that before I connect. So here pyruvate, which is diverted into lactate. So there will be increase in the lactate in 𝗠𝐴𝐲𝐽 disease, and increase in lactate will give rise to lactic acidosis. Lactic acidosis. And this lactic acidosis, note that lactic acid has got a competitive mechanism with uric acid for secretion by renal tubular cells. Whenever lactate builds up, so lactate is going to compete with urate for renal tubular excretion, and that leads to uric acid retention. So that also contributes to higher levels of uric acid. So lactate, elevated lactate will lead to elevated urate in the blood. So overall leading to hyperuricemia, and hyperuricemia causes gouty arthritis. So that's another sign you are going to see in 𝗠𝐴𝐲𝐽 disease. And the final one that I would like to explain is, look at acetyl-CoA, which is coming from pyruvate. Some of these acetyl-CoAs are diverted into ketone bodies. So that means there will be excess ketone bodies in the blood, giving rise to ketoacidosis because of excess ketone bodies getting out into the blood. So like this, so many metabolic abnormalities can be seen related with alternate fate of glucose 6-phosphate. Not only that, this glucose 6-phosphate which is elevated, come back to glucose 6-phosphate now here. Glucose 6-phosphate will have a positive effect on glycogen synthase enzyme. Thereby it is going to increase a glycogen synthesis, and it will have a negative effect on glycogen phosphorylase enzyme. It's going to decrease glycogen degradation. Because elevated glucose 6-phosphate having a allosteric effect on glycogen metabolism. As we have already seen in the regulation of glycogen metabolism, glucose 6-phosphate has got a positive effect on glycogen synthase, negative effect on glycogen phosphorylase. So that means overall glycogen degradation is decreased, glycogen synthesis is increasing, leading to accumulation of glycogen in the liver and in the kidney. That's why patients will show hepatomegaly and renomegaly. So these are other signs that are seen with 𝗠𝐴𝐲𝐽 disease. So now let's put them together. So patient will show, I'm going to highlight that with a green color. Patient will show fasting hypoglycemia. Patients will show lactic acidosis. Patients will show ketoacidosis. Patients will show hyperlipidemia, that includes hypertriacylglycerolemia and hypercholesterolemia. Patient will show hyperuricemia, and that will give rise to gouty arthritis. And also patient will show hepatomegaly and renomegaly. So like this, just a mutation in glucose 6-phosphatase enzyme will lead to so many metabolic abnormalities. So that is what I have written here in this particular slide. Now, coming to laboratory findings that are seen in 𝗠𝐲𝐼𝐻 disease type 1A. So, glycogen and large lipid globules are accumulated in the hepatocytes. Patients will show fasting hypoglycemia, lactic acidosis, ketoacidosis together giving rise to metabolic acidosis. So, and the metabolic acidosis will lead to hyperventilation, and then hyperuricemia, and hyperuricemia giving rise to gouty arthritis, hyperlipidemia giving rise to xanthamas and other lipidemia associated changes. So these are all signs we see in type 1A 𝗠𝐲𝐼𝐻 disease. Now what about type 1B? And note that type 1B is because of a mutation in a gene coding for T1 transporter, and the T1 transporter is the glucose 6-phosphate transporter present in the endoplasmic reticular membrane. If this particular transporter is defective, so it will also give rise to the similar signs and symptoms that you see that I have explained you in 𝗠𝐲𝐼𝐻 disease. All those signs and symptoms are same. Additionally, these patients will show bleeding and infection risk because of neutropenia and neutrophil dysfunction. You need to remember that. So the signs and symptoms of 𝗠𝐲𝐼𝐻 plus bleeding and infection risk will go for glycogen storage 1B because of T1 translocase being defective. Coming to our the next disease is type 2. Glycogen storage disease type 2 is Pompe disease. Pompe's disease is because of mutation in a gene, that is GAA gene, which is coding for acid alpha glucosidase. And this acid alpha glucosidase is also referred as acid maltase enzyme, and which is present in the lysosome. So the deficiency of lysosomal acid maltase, which is a combination of two enzymes here, acid alpha 1,4 glucosidase, which is breaking alpha 1,4 bond of glycogen, which is presented to the lysosome. Remember, about 3% of glycogen present in the cytoplasm is degraded in the lysosomal degradation. About 3% of glycogen present in the cytoplasm is degraded in the lysosome by these enzymes. Acid alpha 1,4 glucosidase breaks alpha 1,4 bond, and acid alpha 1,6 glucosidase will break alpha 1,6 bond and release glucose. Now, Pompe disease, since it is affecting lysosomal acid hydrolases involved in glycogen degradation, so since lysosomes are ubiquitous, present in all cells of our body except red blood cells, so it affects all parts of the body. Only thing is, some organs are more worstly affected than other organs depending on the glycogen quantity in those organs. Now the lysosomes will get distended with the glycogen because glycogen degradation is not going on properly. So glycogen continue to build up as the age increases. So thereby severity of the disease will increase. Now there are three forms of glycogen storage disease. 2, that is Pompe disease, depending on the age of onset. So it is an infantile form and it is the fatal disease. Late onset form, it's a severe disease, and adult form is a mild condition. This is how you can actually give the severity range for infantile, late onset and adult form. So infantile is fatal, late onset is severe, and adult is mild. Now let's look into clinical manifestation of Pompe's disease. Muscle weakness is one of the striking feature of Pompe disease because lysosomes are distended with the glycogen in the muscles, and thereby muscle tone and normal function of the muscle is totally affected. When the tone of the muscle is weak or low, so muscle feels like flaccid, and that's what gives rise to floppy baby appearance, and leg falls outward because of the less muscle tone and the contraction is not there. So that's why patient will show that frog-like position. Even the heart muscle or the cardiac muscles are affected, So that will give rise to severe cardiomegaly, heart rhythm changes, eventually giving rise to heart failure, and often this is the one that causes death in Pompe disease. So remember, the cause of death in Pompe disease most commonly is because of cardiac failure or heart failure. Now the respiratory muscles can be affected because weak diaphragm, so that will give rise to difficulty in breathing, respiratory infections, and eventually respiratory failure, making patient to put on ventilator. Then the feeding and digestion problems can also be seen, again affecting intestinal muscles. So where our digestive system has to contract, like intestine has to do the contraction for the digestion and absorption of dietary macromolecules and other nutrients, so that can be affected here. Now, how do we diagnose Pompe disease? Diagnosis can be done by muscle biopsy, which shows positive staining material, that is peroxide acid skiff stain material will be positive. Electron myography can be done looking for specific changes, myopathic features, and also we can measure alpha glucosidase, acid alpha glucosidase activity in the muscle or cultured fibroblast to confirm the diagnosis. The treatment is glucosidase alpha is used, which is an FDA approved drug. So which is marketed as Myozyme or 𝐒𝐿𝐫𝐢𝐻𝐿𝐺, which is a lysosomal enzyme replacement therapy with promising results. Coming to Cori's disease, which is a glycogen storage disease type 3. The Cori's disease is because of deficiency of glycogen debranching enzyme, and the other name for debranching enzyme is 4,4-transferase, that is amylo 4,4-transferase. What it does? It's going to break alpha 1,4 bond and take the 3 glucose residues and bring it to some other branch and help in the degradation of glycogen. So this glycogen debranching enzyme, that is 4,4-transferase enzyme, it is coded by a AGL gene, and if there is a mutation in AGL gene, it will give rise to Cori's disease. And the disease shows accumulation of branched glycogen with 4 glucose residues, because when a glycogen degradation is going on initiated by glycogen phosphorylase enzyme, let me show you with the structure. I'm going to write one small glycogen branch, glycogen with a branch. All these circles that you see here, consider that those are glucose residues. Alright, so here I am going to number these glucose residues on either side. So 1, 2, 3, 4, 5, 6 residues here. On the other side 1, 2, 3, 4, 5, 6 residues here. Okay, so initially glycogen degradation is done by glycogen phosphorylase enzyme. So what glycogen phosphorylase does, on either side 2 glycogen phosphorylases attacking to these 2 non-reducing ends. So it is going to incorporate inorganic phosphate and break this glucose and release it as glucose 1-phosphate. Similarly on this side, inorganic phosphate, release this as glucose 1-phosphate. Okay, so I'm going to take that out now. So that glucose residue is taken out, and then same thing will happen. Inorganic phosphate has to be incorporated by glycogen phosphorylase and take that glucose out and release it as glucose 1-phosphate. Okay, and again glycogen phosphorylase does the same thing. So at this time glycogen phosphorylase will stop, because the glycogen phosphorylase is going to act on each non-reducing ends and take out 1 glucose at a time as glucose 1-phosphate. And it does that until 4 glucose residues are left at the branch point. Now let's look at this. There are 4 glucose residue at each branch point. That's why I just numbered these glucose molecules. So 4 glucose residues each branch point. Now comes the debranching enzyme. What this debranching enzyme does is going to take 3 glucose residue from one of the branch. So what I will do now is I am going to color it differently so that you follow where it is going to cut. So it's going to cut this alpha 1,4 bond. This is alpha 1,4 bond. It's going to clip it, and then it's going to take those 3 glucose residues. These 3 glucose residues are taken from this branch and it will be transferred here. Okay. So what I'll do is I'm going to rearrange them. I'll write 1, 2 and 3. So I'll also write those numbers coming from 2, 4, 2, 3, 4. Basically they came from other side. Now I'm going to take this part out. So now what we have here is there is a formation of alpha 1,4 bond. So alpha 1,4 bond is broken down and alpha 1,4 bond is created to add these 3 glucose residues. So that's why debranching enzyme here, it is referred as alpha 1,4 to alpha 1,4 transferase. Okay, because it breaks alpha 1,4 bond and it is going to transfer that to other branch and create alpha 1,4 bond. Now that other side branch is elongated by 3 more glucose, and the glycogen phosphorylase will come, is going to add inorganic phosphate here and release this glucose as glucose 1-phosphate, and it's going to go all the way like this. Glucose 1-phosphate molecules will be released. And what about this glucose that is with alpha 1,6 linkase? This is the branch point glucose that will be taken care by alpha 1,6 glucosidase enzyme. This alpha 1,6 glucosidase is going to cut this alpha 1,6 bond here and release this glucose as directly glucose. Glucose will be released there. Okay, that's what happens to alpha 1,6 branch point there. Now the glycogen phosphorylase continue to degrade these glucose molecules, release it as glucose 1-phosphate, and it continues. If there is no branch points, all these molecules released as glucose 1-phosphate. So this is how glycogen degradation is going on. So what happens, my point here, why I was trying to explain this to you is, whenever there is a debranching enzyme deficiency, when 4 glucose residues are left at the branch point, so your debranching enzyme, if it is deficient, it is no longer degrading that partially degraded glycogen. So glycogen will accumulate in that particular shape. So it will be like this. On either side there will be 4 glucose residue. This type of partially degraded glycogen will be seen in Cori's disease. So then 1, 2, 3, 4 on this side, 1, 2, 3, 4 on the other side. Because debranching enzyme has to work here, just as I shown before, it has to break this bond and transfer this entire unit here, right? And that doesn't go on. That's why the type of glycogen that is accumulated in Cori's disease is a partially degraded glycogen with 4 glucose residue left at the branch point. This is what is the characteristic there in terms of type of glycogen that is accumulated, and you need to look for that. Now what are all the clinical signs that you see here? Because of this abnormal type of glycogen being accumulated in the tissues, so the patient will show variable cardiac muscle changes, skeletal muscle changes and liver involvement. So glycogen storage disease 3 is subdivided into 3A, which is the most common subtype, 85%, and 3B is less common, 15%. So clinical course runs like glycogen storage disease type 1, but it is much milder form with hypoglycemia, muscle weakness, hepatomegaly and growth retardation. The most important feature for diagnosis, you need to look for the type of glycogen that is accumulated in this disorder. Look for that. It is an accumulation of branched glycogen with 4 glucose residues left at the branch point. You got to look for that. That's the important clue for the diagnosis. Coming to next disease, that is Andersen disease. Andersen disease is called as amylopectinosis, which is a glycogen storage disease type 4, and this is because of deficiency of branching enzyme, that is amylo 4,6 transferase. Let me correct it here. It is amylo 4,6 transferase. 4 and 6, not 4 and 4. It is 4,6 transferase. Amylo 4,6 transferase means it is alpha 1,4 to alpha 1,6 transferase. So that means it's going to clip alpha 1,4 bond, take a part of the branch and a part of the chain and introduce a branch point. That's how the branching is done. So what happens if this enzyme is deficient? Branching enzyme is deficient means what? What kind of glycogen do you see being accumulated? It is the accumulation of an abnormal type of glycogen with very few branch. Because branching enzyme is deficient, that means very few branches are there in the type of glycogen that you are going to see, right? So it leads to progressive hepatomegaly. Post-patient experiences muscle symptoms such as muscle weakness and muscle cramps. Clinical features are liver insufficiency, abnormalities in the heart and nervous system. But again, just like Cori's disease, you need to look for the type of glycogen that is accumulated to diagnose the condition. In Cori's disease, it is a partially degraded glycogen with 4-glucose residue at the branch point, whereas in Andersen disease, it is the abnormal glycogen with very few branch point. Alright, now let's get into next glycogen storage disease, that is type 5, which is called as McArdle's disease. Now the McArdle's disease is because of deficiency of muscle glycogen phosphorylase, and the muscle glycogen phosphorylase is also called as myophosphorylase enzyme. Now this is the muscle energy disorder because the enzyme that is deficient is specific to muscle tissue, that is muscle glycogen phosphorylase. So the type of tissue that is affected here is the muscle, that is the skeletal muscle. So what happens? The muscle glycogen phosphorylase is the very first enzyme in the degradation of glycogen. So the glycogen degradation do not go on sufficiently. So that's why glycogen kind of accumulates in the skeletal muscle. So especially when a person is doing exercise, so when the muscle contraction is going on, at that time, one of the energy source for the contracting skeletal muscle is the glycogen breakdown, which gives glucose 1-phosphate and then glucose 6-phosphate, and that glucose 6-phosphate has to go into glycolysis, and that process is not going on here. Because of this, what will happen? So because of lack of glycogen degradation, so not much energy will come for muscle contraction during exercise. That's why patient will show exercise intolerance. They won't be able to tolerate the exercise, especially brief exercise of intensities or the intense exercise for a brief period of time, or long duration exercise even if they are less intense. So exercise intolerance will lead to muscle cramps because of lack of energy, lack of ATP formation. And one of the thing that you see in McArdle's disease is something called as second wind phenomenon. This is unique to McArdle's disease, where when a person gets that fatigue, when person becomes fatigued and also gets the muscle cramps when the person is exercising, right? When the activity is lowered, the intensity of the activity, if it is lowered to a tolerable range, and then if the exercise is continued like that, so exercise can be continued and it can be continued for few more minutes or again continued for a while. And that kind of phenomenon, we call it as a second wind phenomenon, which is very unique to McArdle's disease here. Now, because of lack of energy, where glycogen is not broken down into glucose 1-phosphate to provide energy needs of skeletal muscle, so it can affect muscle membrane because ATPs are necessary to maintain the sodium-potassium pump over the skeletal muscle membrane. So skeletal muscle membrane can break open, and that will release the content present in the muscle. One of the content present in the muscle is myoglobin, and the myoglobin appears in the urine, giving rise to myoglobinuria, and it colors urine as a burgundy colored urine there. And also intense myoglobinuria can lead to acute renal failure. Now the diagnosis of McArdle's disease can be done by the presence of myoglobinuria upon exercise. And also, since muscle is breaking open, the contents in the muscle can be found at increased concentration in the blood. That is, if estimation of or determination of serum creatinine kinase (CKMM), which is usually elevated at rest and increases after exercise in these patients. Exercise also increases blood levels of ammonia, inosine, hypoxanthine and uric acid. These are degradation products of purines because of degradation of DNA and RNA. And diagnosis can be helped by doing ischemic exercise test, which is kind of screening test for McArdle's disease, although it is kind of discontinued because during ischemic exercise test we are putting a patient at risk of myoglobinuria, because what we do here is we are going to ask a patient who is suspected to have McArdle's disease. So we put the blood pressure cuff, inflate it for 60 mm of mercury, collect the blood sample prior to the exercise and do lactate and ammonia levels, and note down the lactate and ammonia level before exercise. And then after that, ask the patient to squeeze rubber ball and ask the patient to squeeze rubber ball until the patient gets fatigue and gets muscle cramps. And that means we are trying to initiate that glycogen degradation process in the exercising arm. And now if a person has McArdle's disease, so the glycogen degradation it is not initiated because muscle glycogen phosphorylase is deficient. That means at some point in time, patient will feel fatigue and gets cramps and stop squeezing the rubber ball. At that time, collect the blood sample and again determine the lactate and ammonia level. So the lactate levels, either it will be same as that of prior exercise or it will be decreased. Okay, either it will be same or it will be decreased. That's about lactate. Lactate level post exercise can remain same or it will be decreased because of Cori cycle. And the ammonia level, blood ammonia level will significantly increase post exercise. Why? Because skeletal muscles are breaking down, CKMM increased, and all the content including the amino acids, ammonia, all that will come out into the blood. So blood ammonia level will be elevated. This is a positive ischemic exercise test and patient will be sent for further definitive diagnostic test, that is enzymatic assay in the muscle biopsy, or we can do the gene analysis for myophosphorylase enzyme gene can be done. So this is how McArdle's disease can be diagnosed, and treatment is patient need to avoid getting into exercise which is brief exercise of increased intensity, or it can be long duration exercise even for a less intense but long duration. That kind of exercises can be avoided to avoid get into rhabdomyolysis and myoglobinuria. Coming to Hers disease. Hers disease is because of liver glycogen phosphorylase enzyme deficiency because of 𝐒𝐲𝐫𝐢𝐻 gene mutation. So since liver glycogen phosphorylase enzyme is deficient, liver glycogen degradation not going on sufficiently, and that will give rise to lack of glycogen breakdown, and that causes hypoglycemia. Patient will show hypoglycemia and ketoacidosis, accumulation of glycogen in the liver giving rise to hepatomegaly, and usually this disease runs a mild course unlike other glycogen storage disorders. Now let's get into our next disease, that is glycogen storage disease type 7, which is called as Tarui disease. The Tarui disease is because of a deficiency in an enzyme called phosphofructokinase 1 present in muscle and erythrocyte. Now the muscle and erythrocyte phosphofructokinase 1 enzyme deficiency will lead to Tarui disease, which is grouped under glycogen storage disease type 7. Now, why? And note that phosphofructokinase 1 enzyme, it is a rate limiting enzyme in glycolysis. Now, the rate limiting enzyme in glycolysis, it's a glycolytic pathway enzyme how it is going to lead to glycogen storage in the muscle and erythrocytes, or how it is going to affect. So the thing is, when PFK1 enzyme is deficient, let me show you that how exactly it is connected to glycogen storage disease, especially in the skeletal muscle. So glucose undergoing glycolysis becoming glucose 6-phosphate, glucose 6-phosphate to fructose 6-phosphate, reversible reaction, fructose 6-phosphate into fructose 1,6-BP, and that fructose 1,6-BP goes all the way down into pyruvate, and pyruvate into say lactate. That's anaerobic glycolysis. That's in the red blood cell. Since we have red blood cell here involved, so I'll write anaerobic. Now the enzyme of interest in this disease is PFK1, and our PFK1 is right here, PFK1, which is a regulatory enzyme in glycolysis. So this enzyme is down. So what I will do now is I am going to block this reaction. So PFK1 is deficient. So know that. Let's talk about skeletal muscle and red blood cell now. So when the PFK1 is decreased, activity decreases. So what will happen to fructose 6-phosphate here? Fructose 6-phosphate level will accumulate in the cell, and this fructose 6-phosphate now it will go back into glucose 6-phosphate. Glucose 6-phosphate builds up. Now this glucose 6-phosphate, you need to note that its effect on glycogen synthesis and glycogen degradation. Now the glucose 6-phosphate, as we have already studied the glycogen metabolism regulation, its effect on glycogen synthase and glycogen phosphorylase. So glycogen synthase enzyme, glycogen synthesis, and glycogen phosphorylase enzyme, that is involved in glycogen degradation. So what is the effect of glucose 6-phosphate on glycogen synthase and glycogen phosphorylase? We have studied that in glycogen metabolism regulation. So allosterically, glucose 6-phosphate will have a positive effect on glycogen synthase, and it will have a negative effect on glycogen phosphorylase. That means because glucose 6-phosphate has a positive effect on glycogen synthase, so there will be increase in glycogen in the skeletal muscle and decrease in glycogen degradation. Glycogen degradation decreases. That means energy that has to come for skeletal muscle contraction will also be decreased, because glycogen phosphorylase enzyme activity decreases. Glycogen synthase is increased, means glycogen synthesis increased and accumulates glycogen. Glycogen is accumulated. So that is why in the Tarui disease what happens, because it is affecting muscle and erythrocyte. So the erythrocyte, they are entirely dependent on glycolysis for ATP. Glycolysis is the only pathway for ATP generation for red blood cells. Now PFK1 is the most important enzyme for glycolysis. It is the master controller of glycolysis. That is deficient in the erythrocyte, means red blood cells totally have lack of ATPs there. And lack of ATPs in the red blood cell will lead to RBC lysis, because membrane integrity of the membrane is not maintained because of lack of ATP. Sodium potassium pump fails, means membrane breaks open, and that leads to RBC lysis, and that means hemoglobin will come out, and this hemoglobin will be converted to heme of hemoglobin. So the heme plus globin there separated, and the heme will go into bilirubin formation. Heme is degraded into bilirubin, and especially unconjugated bilirubin. Unconjugated bilirubin will be increased, and that leads to jaundice. Whenever bilirubin is elevated in the blood, leading to jaundice. So on that side we get jaundice there. On the other side, skeletal muscle, when glycogen degradation is not going on because glycogen phosphorylase is down and glycogen accumulates in the skeletal muscle, so energy is not coming from glycogen degradation for contracting skeletal muscle. So patient will develop exercise intolerance. Exercise intolerance and muscle cramps. Exercise intolerance and muscle cramps are seen in Tarui disease. So, signs and symptoms of Tarui disease is very similar to the signs and symptoms that are seen in McArdle's disease, because muscle phosphofructokinase 1 is affected here, where glycogen degradation is affected, glycogen is accumulating. And also additionally, along with the McArdle signs, additionally patient will show signs of hemolysis, and that is jaundice, increase in unconjugated bilirubin and jaundice. So this is what these are the features of Tarui disease: exercise intolerance with hemolytic anemia, increased bilirubin levels, and jaundice is the key feature of Tarui disease that you need to use for the diagnosis process. So exercise intolerance is noted in childhood much earlier and is more severe in Tarui disease than in McArdle's disease. If you are comparing exercise intolerance between McArdle's and Tarui disease is more severe condition. And also here in the previous slide, you need to know the prevalence of disease. The disease is more prevalent in Ashkenazi Jewish population and Japanese population, just in case if that is part of the question, so or the case stem, look for that kind of information. The prevalence, disease prevalence, so it is more prevalent in Ashkenazi Jews and Japanese population. Now, Tarui disease, it is more severe condition than McArdle's disease, and also the second wind phenomenon which is seen in McArdle's disease but not seen in Tarui disease. So that's another differentiating point that you need to look for. So the first differentiating point is prevalence. It is Tarui disease is more prevalent in Ashkenazi Jewish population and Japanese population. Second thing is, along with the muscles, red blood cells are also affected. That means exercise intolerance with the jaundice or increase in bilirubin. That's the second differentiating point. The third differentiating point is disease severity. Tarui disease is more severe than McArdle's disease. And the fourth differentiating point is the second wind phenomenon that I have explained with McArdle's disease. That kind of second wind phenomenon is not seen in Tarui disease. Now, the reduced levels of cardiac muscle phosphofructokinase activity in Tarui disease combined with hematological changes will lead to cardiac hypertrophy in Tarui disease. Similar thing means that kind of feature generally we don't see in McArdle's disease. So, cardiac hypertrophy is one of the feature of Tarui disease that you must remember. So that's about glycogen storage disorders. I have explained all these glycogen storage disorders. Almost all details are given here. So I hope this video has helped you in understanding this very important concept and the clinical application or applied clinical aspects of glycogen metabolism. Thank you.